So, in the name of the Almighty, the most merciful and the most beneficent, I am Professor Syed Ali Haider. I have given you part 5 questions. Few X-rays has been shown to you, and now the answers accordingly to me. Now this is the first X-ray which is shown. A 25-year-old who had recent history of coryza suddenly developed high-grade fever with a dry cough and severe breathlessness. He admitted in ICU when saturation dropped by 75%. A very common scenario. The X-ray is actually shown here with all parameters looking normal except the lung fields. Look very carefully. You compare apex with the apex, first intercostal space with the first intercostal space, second with the second, third with the third, fourth with the fourth, and so on. You see here, this is the highlight area, and here look at this. These are the markings which are coming out. They are not bronchovascular markings, but they are fine type of striations, I would say. Striations coming out from here also. Because bronchovascular marking definition is that it should come out from the hila. It has got broad base, and when it's moving towards the periphery, it will become taper gradually and ends here, and not here. Look, the perihilar in the mid zones and in the lower zones. There are fine striations which are coming out. There are the fine type of bands, you can see. The perihilar type of striations with a scenario with this, and in this zone of Pakistan and India and others, the most likely diagnosis with this is with acute inflammation. Acute inflammation, it may be bacterial to anything. Here is the virus type of the infection, which I propose, in my advice, that it is the typical, I will say very typical X-ray showing these type of changes in the lungs. CT will confirm it although, but the chest X-ray we can pick the changes here and here. This is the primary COVID-19 pneumonia. The differential diagnosis may be anything else can be done, because some of the other organisms can cause this type of the pneumonia, Klebsiella for example. Although it is destructive nature, initially it will spread like this. In the Klebsiella, the upper zones are involved, not the middle and the lower zones. And the other leptospira hemorrhagica, for example, will cause the lesions like this initially, but it will spread very, very quickly to the other areas. Chronic inflammation chances are less because the history is very short. And about the fungi infection is concerned, fungal will not cause these type of striations or the fine type of very fine reticulonodular shadowing. No. Chances are very, very less. The malignant condition will not cause like this. Autoimmune disease can cause this, yes, of course. And the typical example we find in cases of the rheumatoid arthritis, there are lot of variants of skygrams in which these striations, first they are fine and then becomes very coarse and very coarse and very coarse. So the reticulated appearance occurs and fibrotic reaction occurs in the lung. The other diseases related to the sarcoidosis, for example, the perihalar lymphadenopathy, if it is not lymphadenopathy exactly, but the one variant is like this of the sarcoidosis. And another reaction in which it is possibility are the interstitial lung diseases, in which the middle zones are involved predominantly rather than lower zones. Again, fine striations or fine reticulonodular shadowings are seen. These are the differential diagnoses. We go for the HRCT to confirm it. We go for the other tests, which I know you know by heart, that you have to do the CBC, you go for the CRP, and you go for the ELISA D dimer in these conditions, because they are very often causing viremia and causing the autoimmune reaction in the body that end up in the DIC, and picture will mimic the ARDS in the end. Very, very difficult to save this patient if it is. So ELISA D dimer will also be done in these cases. LFT, PT, INR, and UCE will also be done. What you have to do is the recommendations given by either by the American College of Pulmonologists or the British College of Pulmonologists. You can use these steroids, you can use the antiviral like remdesivir, and other antiviral agents can be tried. Where the success rate is not much, although the general measures will fulfill if you will able to go this patient for on the ventilation, properly handling this patient, chances of coming out will be more, rather than go to the fancy type of the drugs which are claimed to be effective. The second X-ray was shown as a 14-year-old boy attacked by the choking during dinner at the restaurant. Received resuscitation and shifted to the ENA, and he had given the history of the facial or oral maxillofacial surgery after head-on collision in the car accident. You know, there will be trauma to the lower jaw, and there will be falling of the teeth, etc. And they put the different type of, for example, the dental plantation in this, or some other procedures they were doing, wiring, etc. As far as the processes, dental processes is concerned, as an implant, then they are using the screws in them. Now this screw is this. Now a screw can be detached if it is possibility by chewing mechanism. In about 5 to 10% of cases it can come out, although there will be no dislodgement of the implant is concerned. This screw will strengthen it. It will come out, and at that time of the choking, actually he engulfed this. And look, this is the carina, the second intercostal space. Here this is the mandibular, this is the sternal angle. This is the first principal bronchus, and divided into upper, middle, and then lower. Now this screw type of thing, which is a foreign body, is actually held here. All the air is going on, but look, the side view. Some part of the lung is collapsed, some segment is collapsed there. It is probably the medial segment, which is lower medial segment, which is involved here. Here this is, dizziness occurs. On the air is also going through this bronchus. The other investigation you will do the lateral view to see exactly the position or HRCT, and then you go for the bronchoscopy and take it out. This is the management. That's all. And give the secondary prevention to this patient by giving the broad spectrum antibiotics so that the pneumonia, which is here, is possibility of a septic type of a pneumonia can occur because it is a foreign body. So you have to cover before it will appear. The secondary prevention should be done in this patient. And then we go for the another X-ray, which is shown was a 50 years old who had history of the wheezing for the last 2 years, given the past history of the full ATT 3 years back. The patient has taken the anti-tuberculosis therapy 3 years back. Now he is complaining of wheezing, 50 years old. It is not bronchial asthma, common bronchial asthma, but it is a refractory type of the bronchial asthma. Now in this case, what is seen is this is the compensated emphysema. There is a here it is haziness, which is their bronchogram pattern. Here it is the compensated emphysema because a very big pathology is there. Although this pathology does not dislodge the trachea or displace the trachea to the other side. Now look this opacity. Here this is a big wall going there. Then there air inside, air in air, and then is again air, and there is a mass inside, a rolling mass. A whorl appearance. This is called Monod sign. This is a typical case of the aspergilloma. Now, aspergilloma is concerning, it is associated with the pulmonary eosinophilia. So, this is the most likely diagnosis in this case, Monod sign. Although this type of lesion can occur as a part of the differential diagnosis, acute inflammation, that is a big abscess which is resolving, or it is a cavity of the tuberculosis cavitation. It may be a fungal associated, other fungal associated cavitations possibility. Although in vaginal glomerulosclerosis there are small cavitating lesions are found. Although in cases of the sarcoidosis, again the cavitation occurs very, very rare, and it is not found with so much big opacity as big opacity. So this is maybe the possible differential diagnosis, and the benign tumors cannot appear like this because cornification and calcification are the main important point, and their radio density is much higher than this. It may be a cavitating bronchogenic carcinoma, okay, fine, but the thing is this type of the picture is not seen with the cavitating bronchogenic carcinoma. If it is, it may be two types: is complete cavitating lesion, or it may associated with a fluid level. So we go for the left lateral view, go for the HRCT, go for the sputum AFB, where you can find the charcot-laden crystals and Cashman spirals in the sputum. You go for IgE levels. You can go for the intradermal test for the Aspergillus fumigatus and confirm it. If it is difficult to confirm, then go for the biopsy, histopathology. It will tell you this is an eosinophilic type of a granuloma. So this is the very typical of Monod sign. That is reflecting the aspergilloma. The treatment is again, you go for the high dose steroids to suppress this, and then you go, if it is not resolving, then go for the removal of this, by surgical removal of this part, because this is the part where the reactivation of tuberculosis can occur. This part, if it is not responded to the therapy take it out. Now this X-ray was shown to you, and there are actually 4 X-rays actually I have shown today, and how I hope so you pick the correct one, the interpretation and the diagnosis, probable diagnosis, differential diagnosis, management strategy, and other investigations. You repeat it and you can understand it. So this is the end of this session, which I have shown you a few X-rays, and inshallah ta'ala on the next day I will go for the other session on it. I hope you good luck for your examinations, and pray to the Almighty that He will thou increase your knowledge of clinical medicine. And remember that you are a clinician, not the radiologist, because you have seen this case, you have examined this case, and then X-ray was done. You are in a better position than the radiologist who is sitting in the room, because you can interpret it well than him. So we'll see next time, inshallah. So good morning and accordingly goodbye.